Hello, everyone. I am Dr. Nabity. I am a clinical psychologist. I'm from the University of Texas Health Science Center at San Antonio in the Department of Psychiatry and Behavioral Sciences. I have no conflicts of interest to report for this talk. I have my background is I've been working with post-traumatic headaches, both in research and working with individuals with post-traumatic headaches for about the last 8 years now. And some of the things I'll talk to you about today are um, just what they are exactly, how they relate to traumatic brain injury, and kind of what we know about the presentation about them and what's the trajectory of post-traumatic headache typically. I'll also talk a little bit about how the differences between the populations, between military populations, veteran populations, and civilian populations when it comes to head injuries and these headaches. And then I'll also talk a little bit about some of the what we know about treatments, and we are slowly moving the needle in terms of improving treatments over time. So I'll discuss some of that as well. So to understand post-traumatic headaches, first people need to understand a little bit about traumatic brain injury and post-concussive symptoms. So worldwide numbers from the DoD as far as traumatic brain injury diagnoses over the last 23 years, from 2000 to 2023. There have been almost 500,000 diagnoses in the military, and a little over 80% of those are mild TBI. The remainder are moderate to severe. Um, and for U.S. civilians, there's quite a few head injuries in this country per year between 2006 and 2010. The emergency visits with the traumatic brain injury diagnosis was over 2 million during this time frame. So that's roughly about 500,000 significant head injuries in this country per year. So it's a significant issue in civilians as well. And the most common post-concussive symptoms of a traumatic brain injury include dizziness, fatigue, headaches, vertigo, and tinnitus. We see a lot of tinnitus, especially with veterans. Memory, concentration, and sleep problems. There's also restlessness and irritability, anxiety, apathy and depression, also noise, light sensitivity. Sometimes you'll see people with post-traumatic headaches wearing sunglasses, even indoors, and personality changes. These can all come along with TBI and the post-concussive symptoms. And some people who might be aware of the overlap with PTSD might notice that there is overlap there, especially with memory, concentration, sleep problems, the restlessness and irritability and anxiety and depression. All those symptoms can overlap with PTSD as well. So, what is a post-traumatic headache? According to the International Classification of Headache Disorders, the third edition, there are these primary headaches, which are the ones that we typically think about, such as migraine, tension type headache, trigeminal cephalgias, and other primary headaches. And then there's these headaches that are called secondary headaches, and this is where post-traumatic headache fits in. So a post-traumatic headache is a headache attributed to trauma or injury to the head or neck. And then there's other secondary headaches as well, which could be used due to substances or infections or other causes. Um, and then there's also this difference between acute and persistent. When we're talking acute with headaches, we're talking less than 3 months. That's the acute phase. When we're talking persistent, we're talking 3 months or greater. Now, in the pain world, they oftentimes mix the words chronic and persistent, but in the headache world, the word persistent is used when it's beyond the acute phase. Chronic means something very completely different in the headache world. Um, and these injuries, according to the criteria, need to have developed within 7 days of an injury to the head or neck. or from with regaining consciousness following the injury to the head. So if they're in a coma, once they wake up, if they have a headache within 7 days, that still is a post-traumatic headache. Or after discontinuation of any medications that may impair sense to report headache or head from a head injury. And this headache cannot be better accounted for by some other diagnosis, such as seizure activity or tumors or other things. Now, this 7 day inclusion criteria is considered by some as too strict. Others think it's maybe a little bit too liberal. Some of the reasons to doubt the 7 day inclusion criteria are explained on this next slide from a prior study that's been published already. What was found was about two-thirds recognized that they had a headache within 7 days of the head injury initially, and then about one-third of the population didn't realize there was a change in their headache status until after that time frame. And in this particular analysis, there was no difference between the phenotypic patterns that they were describing, or demographic variables, or rank, or branch of service, or anything like that. So one of the differences that's particular to the military is blast injuries. A fair number of traumatic brain injuries and post-traumatic headaches occur after blast injuries, especially considering some of the nature of some of the conflicts that have occurred abroad in the last 20 years. Now that's compared to blunt head injuries, which are things like hitting the head on the ground, or hitting the head during a car accident on some object, or being hit in the head by some object. And then there's also what I would call combination injuries. Sometimes even in the context of a blast, blunt head trauma can also occur where somebody's knocked off their feet and they may hit their head on a wall or on the ground or some other object. Some other kinds of injuries that are seen during active duty could be falls, vehicle rollovers, hit by objects, penetration by foreign objects such as bullets or shrapnel. And then the most frequently seen thing, especially for individuals that are deployed in these conflicts, are some sort of explosive force. So this could be like an IED, it could be like a mortar, rockets, or even sometimes friendly detonations that occur as part of people's job occupations. Um, and in different studies that have been done in the last 15 years, most of these head injuries and post-traumatic headaches that are starting after these headaches or head injuries are by explosions. And in a study we actually did through the UT Health Science Center here in San Antonio, what we found is about 49% of our veterans with post-traumatic headaches in that study had a blast head injury. 34% had a blunt head injury, and then 17% had a combination injury. And the combination ended up being worse than either alone as far as chronicity of headaches. Chronicity of headaches refers to the frequency of headaches per month. If they're chronic, it's 15 or more headache days per month. Now compare this to a civilian population of post-traumatic headache. Civilian headaches, post-traumatic headaches are mostly due to car accidents, followed by falls off ladders, falls on sidewalks, falls on ice, different kinds of falls. And then sports related, and then after that, it's violence or other things. Um, and when it comes to sports, especially over time, that's probably become a slightly more prevalent here in the United States as far as civilian causes of post-traumatic headache, just simply because of the some of the violence that occurs in our sports, and people are bigger, stronger, faster now than they've ever been in the past in sports. When I was in high school, we did not have 300-pound linemen on the line, but now that's a more common thing. So that just results in more violent impacts. And what a lot of people don't realize is soccer is pretty hard on the head, and that's also another sports related head injury that occurs that can lead to these headaches. Okay. So, how do they present in the military? And this is fairly true of some civilian populations as well. Presentation usually is migraine-like. And I use the word migraine-like because they are not necessarily migraines. These are secondary headaches, not primary headaches. But they're often explained as migraine-like because they oftentimes will have pain severities that are high, sometimes 6 out of 10 for pain, 7 out of 10, 8 out of 10, 9 for 10. They tend to be people who would have these headaches tend to report higher pain levels. People who have these headaches also sometimes have aura symptoms, which we would see with migraine. There's such a thing as migraine with aura symptoms. These are symptoms that occur before the head pain itself actually starts. And with post-traumatic headache populations, at least in our population that we examined several years ago, of veterans with post-traumatic headaches, we saw about one-fourth of individuals had migraine, like with aura symptoms. And the remainder, in most studies, it's about a three-fourths migraine-like to one-fourth tension type like being less pain and more bilateral on both hemispheres. And these are some of the phenotypic characteristics we saw in a former study. Now, one thing that might stand out is most of this population was male, only a small percentage was female. Which is characteristic of what we see in veterans with post-traumatic headaches. It's usually more males that end up with these than females. Part of that might be due to just different duties in their jobs, whether it's in the military or just risk-taking activities even outside of the military. And the pain characteristics that they experience, several of these individuals have had these headaches for years. And I'll talk about the trajectory of these headaches in a moment. The average pain rating was a 7. The average duration of these headaches was about 4 hours. So that's why they typically are described as more migraine-like. Episodes per month on average for these veterans with post-traumatic headaches were about 12 episodes per month, which is quite a few. And unfortunately, a small percentage, 16 out of 193, had what are called unremitting headaches. And these are headaches that are, as they sound, they're unremitting, they're ever present. Every time they're awake, they're feeling this head pain. Pain locations vary, but they typically are more towards the front, side, and top. And it's about half and half of it as far as reporting a more a pulsating quality that you would see more with like a migraine or a pressing quality that you see more with tension type headaches. And rates of photophobia, so an aversion to light, or phonophobia, an aversion to noises. Those tend to be high with these headaches, but that's also fairly high with just anybody with a traumatic brain injury. Those are very common symptoms with traumatic brain injury in general. About half the population that we worked with in the former study reported some nausea with their headaches, and about a quarter reported some vomiting, and about another quarter reported some aura symptoms prior to the headaches. And the most common of those were dizziness, blurred vision, and ringing in the ears. We had a fair number of people with tinnitus in that population. And some of those individuals had ringing in the ears that worsened before those headaches. So incidents, this is a publication that I put out a few years ago looking at incidents in the military between 2008 and 2015. And here's what's interesting about this. The incidence in reporting of these headaches actually rose gradually over time. But if you compare that to TBI cases over the same time frame, the two lines are different. And in the second graph here, you can see the line below is the new cases of the like headaches reported between 2008 compared and through 2015 compared to TBI, and the PTH cases rise, but the TBI cases do not rise. And there are a number of reasons for these differences in the underreporting of post-traumatic headache. Probably two of the more common ones are medical doctors just oftentimes don't think to ask, did your headache start after a head injury? And patients don't necessarily think to report it, that their headache started after a head injury. So I think that's probably a large part of why there's underreporting of these headaches. Part of it's probably just a lack of awareness, lack of education. There are several other reasons that could explain some of the underreporting, which are in the article. I will, for sake of time, I will not get into those in this talk. But as talks like this are done across the country, awareness will increase, and hopefully we will have more consistent and accurate reporting over time of the true incidence and true prevalence of these post-traumatic headaches in our population, both military and civilians. As far as prevalence goes, there's a number of different studies. Some of the prevalence rates vary a bit, but there are some consistencies also. We know on the high side, up to 85% of individuals do report headaches after a concussion. And we also know on the lower side, long term, that about 15%, so about 1 out of 6 that end up having a traumatic brain injury end up with headaches long term. And then in the middle, there's a more recent study by Ashina and others where what they showed was acute post-traumatic headaches. So headaches 2 weeks after the head injury is about 60%, so about 3 out of 5. Persistent post-traumatic headache at 3 months is about half of individuals with a traumatic brain injury. Going out to 6 months, it drops to about 37%. And then going out to a year after the head injury, it drops to about 29%. So the good news is for the majority of individuals after a head injury, even if they do have a headache afterwards, most of those individuals will not have that headache a year later. Unfortunately, for some people, they will have that headache a year later. And if you go further out, it's about 1 out of 5, 1 out of 6 that end up having these headaches for years upon years. Okay. So I'll talk just a little bit more about traumatic brain injuries, since these headaches start after a brain injury. And nationwide, estimates are there's potentially about 1.5 million traumatic brain injuries in this country per year. I think that's probably a slightly high number than the reality, but that's what one study estimated. Most people with them end up with a mild traumatic brain injury, and most individuals with a mild traumatic brain injury fully recover within about 3 months. And of the most common symptoms, headache is one of them. The civilian incidence is about 200 per 100,000 individuals per year. And in the military, here's a graph showing the diagnosis per year from 2000 to 2020. And you'll notice as various conflicts have happened across the world, we see a spike. And then as those conflicts kind of wound down a bit, we've seen a drop in TBI diagnosis in the military. Now, what we would expect with post-traumatic headache, if reporting more accurately reflected the actual TBI diagnosis, we'd expect that would follow a fairly similar curve for the graph for post-traumatic headaches. So next, I will talk about some of the things that are also found co-occurring with post-traumatic headaches. Frequently, we see a triad that occurs with these headaches because they occur after a TBI. There's TBI. A lot of times, because of the nature of the context of the injury itself, especially if it's a blast injury, especially if people might have been killed, or it was a car accident where there could have been death or was risk of death. There's a lot of times there's comorbid PTSD, and then oftentimes there's also comorbid depression with these headaches. And individuals with these persistent headaches, these headaches that last 3 months or longer, they're more likely to have this triad than those with no additional comorbidity beyond the traumatic brain injury itself. And then from our former study, what we found in terms of chronicity versus episodic. So chronic is 15 or more headache days per month. Episodic is 14 or less headache days per month. We found it's about a 50-50 split in veterans that we worked with post-traumatic headache. So if you stop and think about that for a moment, just think about somebody trying to function with these headaches. If about half the population, half the veterans that have these are likely to have 15 or more headache days a month. Just think for a moment how that might affect their family life, if they're trying to work and hold down a job, how that could affect their work functioning, or if they're trying to go back to school, how that could affect, trying to study and that sort of thing and further their education. Or just general overall well-being, how that is to live with 15 or more head pain days per month. You can get a sense of what the impact of these headaches are, especially when they frequently present as migraine-like, very much more painful. Okay. And looking at a little bit more at these comorbidities, especially with the traumatic brain injury and PTSD, one study showed a 1 year trajectory where about half the population stayed about the same over the course of the year. About 30% reported a worsening in their headaches over the year, and about 23% improved. So once it becomes fairly persistent, they do tend to be a little more on the stable side and making improvements. It's just more difficult over time. Okay. So that gets into an overview of some of the treatments of PTH. Now, this slide, this is treatments that are out there. Just because these treatments are on the slide does not mean they're effective. I'm just reporting on some of the different things that different doctors attempt to address these headaches with. Um, there's still a lot of research that needs to be done to find actually effective treatments and come up with better guidelines. Currently, there are no guidelines, or at least formal guidelines, for how to best treat these headaches. But with further research, we should come up with some better solutions for these headaches. One is just non-steroidal anti-inflammatory drugs, NSAIDs, things like aspirin, acetaminophen, naproxen, things like that. Triptans are sometimes used, or other migraine medications. Sometimes antidepressants are used, whether it's tricyclics or SSRIs. Botox, botulinum toxin A is sometimes used for these headaches, and that's frequently recommended within VA systems. Prazosin is sometimes used for these headaches, and there is some evidence, which I'll show in just a second, that that can potentially help with these headaches and help improve them. and lessen their frequency. Some people also go to complementary medicine because they've tried all sorts of things and just had difficulty finding things that work. So people have tried chiropractic, acupuncture, massage therapy, physical therapy, something called thermozone, which is essentially a cold and heat compress, alpha stem, prescriptive sunglasses. People end up turning to all sorts of things in complementary medicine for to try to treat their headaches and get some relief. Also, cognitive behavioral therapy has been used for these headaches, and I'll report some results from an 8-session protocol that was used for these headaches in order to manage these headaches and get some relief there as well and improve functioning. So I'll start with some of the pharmacological treatment, and then I'll talk about some of the non-pharmacological treatments that are being investigated or used. So when it comes to prazosin, there's been so far, there's been one controlled, randomized controlled pilot trial. This is a fairly small trial, so it still needs to be replicated to see if the effects hold up in a larger population and across sites. But what they found is that prazosin, which is also sometimes used for nightmares and PTSD and other reasons, seems to help with these headaches as well. 70% of the individuals that were in the prazosin group compared to 30% in the placebo had about a 50% reduction in their headache frequency, which is pretty notable. And their headache impact test. So this headache impact test measures functioning with these headaches and the impact on various areas of their life. Their scores were 6.6 points lower for the prazosin group compared to the control group. And that is a significant drop. That is a clinically significant drop in that score. And then with botulinum toxin type A, there was also a similar sized pilot trial done with this with veterans, where they did a crossover at 16 weeks post-injection. And then on average, what they found was there was about 1.5 decreased headache days per week, which is a noticeable decrease in frequency, and then some pain reduction in the headaches themselves of about 1 to 2 points. And clinically significant pain reductions, it depends on what study you read, but a pain reduction of about 1.5 or 2 points is usually considered clinically significant on a 10-point scale. Okay. So I'm going to talk a little bit more about research I've been involved with in the last several years. This cognitive behavioral therapy for headaches that we used for veterans with post-traumatic headaches. It involved 8 sessions. These were 40 to 55 minutes long each. And these were psychotherapy sessions, so they were administered by a mental health practitioner, and it follows a stress, tension, headache model. Basically, they learn how to better manage their stress and that muscular tension, and in doing so, that actually lessens their headache and increases their functioning. And some of the skills training involved are relaxation skills. So relaxation skills such as breathing techniques, muscle relaxation techniques, hand warming biofeedback, which is a mental hand warming exercise that relaxes the body, and several other relaxation skills are part of that. And then it also involves stress management by other means, such as structured problem solving, just teaching people how to identify some of the stressors they're dealing with, how to clarify those problems, and how to go through a structured problem solving approach to address those problems and make them less of a problem, making them less stressful. This protocol also involved management of headaches after onset, so teaching people some skills on how to function even with the headaches themselves. And it also worked on increasing awareness of triggers that are related to headaches and things that make the headaches better and things that make the headaches worse. So in essence, they were trained to become better managers of their headaches so that the headaches were less frequent, hopefully less painful, and less impactful in their life. And the whole goal was to improve their functioning, improve their home life, work life, or other areas of their life. Okay. And their HITSIS score. So again, this is a measure of functioning. It covers a lot of life domains as far as their functioning with their headaches. Those that received the 8 session protocol had clinically significant improvements, even out to 6 months after the protocol was delivered, with their headaches. And they actually even had just a slight improvement over time, even after the protocol ended. And the notable thing is their post-traumatic their PTSD symptoms also improved. A lot of veterans with post-traumatic headache also have comorbid PTSD, and this was not a trauma-focused therapy, and still it had outcomes in terms of reduction of PTSD symptoms that were pretty similar to what you would expect for trauma-focused therapy, and that was a surprising result of that study. Okay. Some other things we found from that study are that anxiety explains part of the improvements in the headache. Not as much as I would have expected. If this was a pizza pie with 10 slices, anxiety explains about 1 out of the 10 slices, which means there's a lot of other things that are influencing these improvements in these post-traumatic headaches. So there's still a lot of research that needs to be done to understand what are the mechanisms of improvement with these headaches and how can we tailor our treatments to get more improvements by understanding what leads to those improvements. And then lastly, I'll finish off with a study I did over the last couple of years. This was a small pilot study, and this is involves psychologically informed therapeutic massage. So it's incorporating some of what we know from psychology and bringing that into the massage therapy milieu. So essentially, teaching a massage therapist how to teach others relaxation skills training as part of that massage milieu. And bringing in more awareness of potential headache triggers as part of the education piece with this protocol. And what I did is I created an 8 session protocol, in some ways a little bit similar to our cognitive behavioral therapy protocol, but really trimmed down to where individuals would receive about 40 minutes of a massage tailored more towards what would be done for people with headaches. So mostly head and neck massage, along with just a little bit, about 5 minutes or so of relaxation skills training embedded with that, and a little bit of awareness of potential headache triggers embedded within that. So a very simple combination of these two things, a little bit from psychology and what we know from psychology that can help with these headaches, and the massage itself for these headaches. And then what we found is, of the 3 that we considered enrolled, 1 dropped prior to treatment, but of the 2 veterans that received this treatment, 1 veteran received all 8 sessions, and a second veteran received 5 sessions. And both veterans had daily headaches prior to this treatment, even in spite of all their prior treatments that occurred before coming into the study. And both veterans ended up trying a lot of things prior to coming into the study. And they had 7 headache days per week. After this treatment, they had 4 headache days a week. Now, we don't know about duration of these treatments, and it was an open label treatment. So they were able to continue whatever treatments they were doing normally for their headaches. It was not a highly controlled trial, but it is some promising information and some promising evidence that this approach might be beneficial for these post-traumatic headaches, and it's certainly worthy of further research. And we do intend on researching this particular treatment further for these post-traumatic headaches. to see if we can add to the non-pharmacological options for treatment of post-traumatic headaches. Okay. So, in summary, when it comes to military populations and veterans, post-traumatic headache is a significant problem. It's also a significant problem in civilians as well, considering the number of car accidents in this country per year, falls per year, sports injuries per year. Though most of the research in the United States tends to be on military, active duty military, and veteran populations. Whereas in most countries abroad, their research tends to be more focused on civilians. Traditional medical approaches are known to have limited effectiveness, but there is some empirical support for treatment, such as cognitive behavioral therapy and some of the pilot study information for prazosin and monobotulinum toxin A. And more research is needed to provide more empirically driven guidance about treatments and also to better understand the mechanisms of post-traumatic headache. So we have moved the needle a bit in the last 10 years. So that's a good sign, but there's still a lot more research to be done. And that is my presentation. So I will open it to any questions.